I don't have nearly as many things to say as my colleague from London here about the future, because I don't have the same crystal ball that he has. I can only talk about a few things, and I think that that it all has to come together. The things that Billy talked about, and the things that I'm going to mention, to make sure that we really are paying attention to the future for these kids. I think it's safe to say, as we've seen today, the curves that increase are not just there to look at. They actually mean that more patients are coming. And I think that the idea of having an obesity specialist at every hospital, I think that the idea of having more pediatric surgeons probably involved in the future is going to be necessary. Although, to be honest, most of the people in my specialty really don't take care of obese patients, don't know how to take care surgically of obese patients. And that has implications not only for the fact that many of them will need surgical procedures, but also for the fact that many of them will need appendectomies as well. And taking care of the seriously obese patients in a hospital setting doing general surgery really does put them at risk for a number of complications that our healthcare authorities, that credential hospitals, and that try to make hospitals a safe place are very worried about for the future. In terms of bariatric considerations, I think really that the very young is a topic that is emerging. It seems to be emerging mostly from outside the U.S. right now, but I'm not sure how many cases of preteens are being done in the U.S. as well. But we are seeing case reports emerge that I don't really understand the basis of, cases of 2-year-olds or 5-year-olds or 8-year-olds. The details are really not well publicized in these case reports or case series. The details, that is, that would allow one to understand exactly what these surgeons or physicians that are treating these very young children are being motivated most by. I do agree that syndromic and hypothalamic forms of obesity are another challenging area that the future will require us to address. There was recently a 2020 segment about a Prader-Willi patient that was, doing actually reasonably well for someone with that condition, but in a group home setting with things very, very regimented and controlled. And we know that kind of a group home, very controlled setting is not possible for everyone with that syndrome. And we know that there are other monogenic forms of obesity and polygenic forms of syndromic obesity that do not lend themselves to good treatment options. We've had a number now of the hypothalamic patients, and I have a little vignette that I'll show on that topic and discuss a bit more. But certainly am eager to hear thoughts about these specialty areas and how we can gather more knowledge, how we can put that knowledge into a treatment paradigm or a thinking paradigm, so that we don't just have to say to these families that are quite desperate, that surgery doesn't appear to have a role, or we don't know, what is the role of surgery. I would like to see more structure to that. I'm as skeptical as the next guy about some of these cases, and surgical history for some of these conditions is replete with bad outcomes. But I think that these are things, nonetheless, that we have to address as modern physicians and modern surgeons. There is the problem of the failures. So I talked about a very powerful intervention, as did Torsten and others today, in surgical procedures. But even with these most rigorous interventions that involve invasive rearrangements of the gut, we have patients who are in that quote-unquote non-responder category or weight regainer category. And I think that a challenge there will be to more accurately phenotype them, more accurately perhaps genotype them as well to explore this concept of surgical response genes, similar to the notion that some of us, have a great response to a particular anti-epileptic medication, and some are poor responders, and that these discrepancies can be sorted out and the genes responsible identified, so that you can understand whether the drug is going to be effective for your patients. I think that there's probably some similarities to the surgical response as well. That's what Lee Kaplan has begun to elucidate in his lab. So I think that this will be a real multifactorial problem to sort out, the weight loss failures and what to do with these patients, whether there might be novel procedures that are useful, or adjuvant pharmacotherapy is certainly an open question. And then, of course, recognition and avoidance and treatment of adverse effects of bariatric surgery, or what we fondly refer to as bariatric surgical diseases that we create that need to be dealt with. And certainly the information that you saw today about PTH elevations is concerning. I think that the bone density literature, the bone density explorations or investigations have really not been done that are long-term, and that would be reassuring and would be allowing us to address this more directly. I think that certainly looking at mechanistic studies and looking at saved specimens and trying to really understand, what is it that surgery is doing that could be recreated with another form of treatment that really could be put into a pill, or put into a smart device that you carried, or put into a less invasively deployed intervention is quite intriguing. And I think that there certainly are a number of industry partners who are interested in exploiting, for the good, a good use of the word, exploiting knowledge that we can gain from how surgery is doing what it's doing for those who are successful with it. So in terms of forecasting, I'm no statistician, you all know that, but there are statisticians that are looking at the data, the prevalence data and the trending data, and are predicting really a very lousy trajectory here for prevalence of morbid obesity. This is work done by the CDC that really looks at a doubling in the next decade or so of the percentage of patients in the U.S. who are morbidly obese. And so that's, again, what I'm using as a basis for being worried about not only teens but also adults, and how we're going to take care of them. This is a 6-year-old from Trinidad who had a BMI of 53. Of course, a 6-year-old is quite short, so not quite as heavy as some that we're operating on, but nonetheless with an impressive BMI, who had Blount's disease. That's the tibia vera deformity of the knees that you see in the slide, and a bad quality of life. And this patient did undergo a sleeve gastrectomy, again, early on at this age of 6. And, this is what some editorials have considered as uncharted territory. I think that there was an editorial about another young patient, maybe it was the 2.5-year-old that underwent surgery in Saudi, that had one expert speculating or likening this to a deep space probe that is kind of lost its connection to the home base. No one knows where it's going. No one knows what's going to happen to that deep space probe. And that is, I think a very valid concern for the very young. And I think it's the onus is on, I guess, the folks who are taking care of these very, very young and taking care of them surgically, to explain to the rest of us, what in fact are the are the motivating factors, the real problems that they're seeing, because we're not seeing that in the US, and I don't know the extent to which that's being seen in Europe, that 2-year-olds or 5-year-olds are needing to have surgery. I don't want to pontificate and say that this is just absolutely something that can't ever be considered, because as soon as you become that black and white in your thinking, you're sure to be proven wrong at some point down the road. And so I think at the very least, we really do have to understand why, and have a real solid follow-up to find out what has happened in these cases that are being done, so that we can know whether good was done or, on balance, harm was done. This is Alexis Shapiro, and I didn't get her HIPAA release or her privacy release from her mom, because she's really been all over the internet. Her mom was very vocal about the problem that developed with this child. This is a picture of her at age 9, and then this is a picture of her at age 10 when she underwent a craniotomy for a craniopharyngioma resection that involved, as most do, a portion of her brain, pituitary, and hypothalamus that ended up resulting in damage to the very important real estate that Carl talked to us about in the arcuate nucleus, and led her to really double her weight in the course of about a year and a half's time, and develop terrible sleep apnea, develop terrible non-alcoholic steatohepatitis, develop diabetes. And this is one of those, quite fascinating as a clinician, of course, but awful as a human being, cases that you're really dealt a really bad hand, and you have a very normal child 1 year, and the next a different child, as her mom says. And so what can modern science, what can modern medicine, what can modern surgery do to help these kids that really, if you appreciate the fact that there are many in society, my society and your society, that still are stuck on the mentality of all these folks have to do is put the fork down, that's not the case with these children, for sure. And there really is a great deal of concern about what will happen to them, and whether or not surgery is right. I think that there's probably a little bit more enthusiasm for offering surgery in these cases because this is a more of a definable condition, unlike, say, the genetics of Prader-Willi and the other syndromes that are not so discretely defined. This is Alexis's trajectory. So this is very typical of what happens with craniopharyngioma patients that have a hypothalamic injury in the area that regulates energy balance after brain surgery. They have an enormous weight gain. As you see here, she was right about 55 pounds at the time of the surgery, and as you can tell, she was in the between the 5th and the 10th percentile for her weight for age. She had actually stopped growing a year or two before this. She was no longer growing in linear height, and then had a very dramatic weight gain, and came to us at 187 pounds. And then while we were working with the family and working with their insurance company, she gained even more weight, despite what you would consider, a very strong preoperative weight loss intervention. It's a very weak intervention when you compare that to the forces that are causing her to gain weight. Michael and I had the honor of taking her to the operating room and being caught by surprise when we found a liver that was a formidable enemy, and had planned to do a gastric bypass. But we could not, we're not faint of heart, he and I, but we couldn't move that liver. We couldn't get a good view, actually, of the GE junction, and ended up making the decision that I'm hoping was the wisest decision to not back out, but to sleeve her. So for a sleeve gastrectomy, really the surgeon just has to have a very good appreciation of the left side of the stomach and the left side of the fundus area, not the right side. So that was a successful procedure, and you can see here her weight loss over the ensuing number of months. She's now lost, I think, about 50 pounds. So, but that was, again, just one of a small series that we have of hypothalamic patients. It was probably our 9th or 10th patient, but a group in Paris felt like this was a topic that needed to be reviewed, and reviewed this and pulled together data from a lot of centers that had published, as we had previously on this topic. But in this meta-analysis, it was only 21 such cases, 6 gastric bands and 8 sleeve gastrectomies and 6 gastric bypasses. And the BMI change was not what we would want to see in say, patients without a central driver of obesity. I think that the best outcome for this was in the gastric bypass group, and far inferior results, say, with the banding group. But this is another, again, one of those areas. This is just an example of another one of those areas that is a special form of obesity, of pediatric obesity, that I think deserves special attention. To that end, we actually put together a registry to begin to catalog rare forms of central obesity and have it as a web-based. I think we were the first in our own institution to have a web-based consent process that got through the IRB and was acceptable. But with this project, there is an informational website and a registry, and the goal is not just to have a registry for a registry's purposes, but to have a registry that someone like Dr. LaRue here, or someone in industry is trying to develop a drug that acts centrally, might then have patients that could be recruitable to a study. So we're just realizing that for rare conditions especially, it's hard to study them because people don't have a big cohort to look at. Are there other procedures that we maybe need to be prepared to examine? Yes. I think that the success of the ban or lack thereof should be no impediment to us beginning to think seriously about the pipeline of devices that may be coming down the road, and that may include this liner. I have no interest or financial interest in any of these companies or devices, by the way. But the liner that really acts much like an internal bypass has been shown to be helpful in diabetics. And does this have a role, for instance, in weight management or in treatment of adolescent diabetics? There are certainly innovative groups that are looking at ways to reduce gastric volume by not removing the stomach, but instead by replacing that volume with an inert substance like a balloon. So innovation is a good thing, but we also need to, of course, be able to discriminate between good innovation and snake oil, of course, and advise the regulators about how best to get devices from idea to laboratory to the clinic. So I think that is really an important area, and again, the failures, the nutritional deficiencies, and really realizing when we look at the adverse outcomes of surgery, we have to also realize that there are very adverse outcomes of not operating as well for these particularly very severely obese patients. So with that, I will stop.